Very good afternoon, all the participants. Myself, Dr. PRAKASH NIDWANI, the professor at the Department of Prosthodontics and Implantology, Navodaya Dental College, Raichur. Before I dwell into the topic, I would like to congratulate the PROSTHONEXUS 2025 organizing team, Department of Prosthodontics, HKES'S, NIJALINGAPPA Institute of Dental Sciences, Gulbarga, headed by Dr. Arvind Modi, my dear friend, Dr. Swati Bewani, Dr. Varsha Jabshetty, for giving me this opportunity to be presenting my topic before you. I also would like to recollect the contributions of IPF's Karnataka chapter, Dr. Anand Patil, the president, Dr. Umesh Pai, the secretary, Dr. Konar Patil, the treasurer, and all the dynamic EC members for their effort in organizing this PROSTHONEXUS. Thank you. As today, I would like to discuss on a soft tissue management and impressions in fixed partial denture. And though this topic I'll have to cover it within 1 hour, I would like to concentrate on a high yielding points throughout my discussion. Gingival retraction or displacement is a deflection of marginal gingiva away from the tooth, which is a very essential step for a successful prosthodontic restorations in FPD. Gingival retraction has two components, basically the lateral displacement and the apical or vertical displacement. The lateral displacement is the displacement of tissue so that adequate bulk of impression material can be interfaced with the prepared tooth so that we can record the finish line adequately. Apical displacement may cause trauma to the gingival tissue followed by recession. So this means we should be encouraging a lateral displacement more than the apical or vertical displacement. Why gingival retraction? So this is a very essential thing to know that gingival retraction gives us adequate space for the impression material to flow and record the finish line, and this also helps in providing a good contour of our restorations, and thus it can provide a good marginal integrity to our prosthodontic restorations. This is very essential step in order to record a good finish line, and the part of a tooth apical to the finish line is also important for contouring our restorations. Classifications of soft tissue retractions by Barkmere and Williams in 1978. He described them as a non-surgical and surgical methods. In non-surgicals, we have rubber dam and clamps, retraction cords, retraction rings, copper band technique. Whereas in surgical, we have gingivectomy and gingivoplasty procedures, rotary gingival curettage, and electrosurgery. And another classification by Benson et al. In 1986, he classified the methods as mechanical method, mechanochemical method, rotary gingival curettage, and electrosurgical method. Mechanical methods are the first to be developed, which causes mechanical physical displacement of gingival tissue. This used alone, or it may be used in conjunction with some other methods. Usually the mechanical methods, the first one is rubber dam placement, cotton twills with zinc oxide enol cement, which is a quick setting zinc oxide cement we have to use, copper band impression, retraction rings can also be used. Rubber dam basically was invented by Baron in New York City in 1864, and this is nothing but we are all very familiar with this procedure of a thin latex sheet which creates a barrier between the working field and rest of the mouth. The advantage of this technique is it controls the seepage and hemorrhage, and it has got a ease of application. Whereas the disadvantages, it cannot be used as a retraction technique for a full mouth models, and it can be used in preparations with minimal subgingival preparation. Cotton quills with zinc oxide cement, which employs a gentle pressure over a period of time of zinc oxide is mixed into a creamy consistency and the cotton quills rolled into the mass, and this is packed in place with a fast setting zinc oxide cement, minimum of 48 hours or not more than 7 days. Basically, this method, the disadvantages may be saccular hemorrhage during packing, or it is not a quick procedure. It is a time consuming procedure. You will have to wait for the results. The copper band impression technique, which was a quite older technique wherein we select the appropriate size copper band and we adapt it around the tooth, and the cervical margin needs to be festooned, cut into the to fit the gingival crevice. Once we do this, then the copper band can be filled with the impression compound, or it may be filled with a elastomeric putty impression material, or a gutta percha, or autopolymerizing resin. So this entire process may ensure mechanical pushing of the free gingival margin away from the finish line. Retraction rings, these are nothing but a various size of rings, flexible rings which are available, and they can be used for pushing it around the neck of a tooth to achieve a mechanical retraction. Mechanochemical method, this is the second method of retraction, wherein in mechanical we use only the cords or the strings to displace the tissue. In the chemical method, the strings are or the cords are soaked with number of chemical compounds, which can cause temporary shrinkage of the tissues, and it also adds to the control of hemorrhage and fluid seepage. Thus, it will give us a dry field, and it will also help us in doing the effective gingival retraction. The chemicals used commonly can be classified as a vasoconstrictor, biologic fluid coagulants, or surface layer tissue coagulants. Usually the vasoconstrictor of 0.1% to 0.8% epinephrine can be used. Biologic fluid coagulants, as the name suggests, it coagulates on the surface, and it also causes the amount of tissue coagulation on the surface of the tissues. Usually 100% alum solution, that is potassium aluminum sulfate, or 15 to 25% of aluminum chloride solution, 13.3% ferric sulfate solution, 15 to 25% of tannic acid solution can be used. Surface layer tissue coagulants, this, as the name suggests, these coagulate the surface layer and forms an impermeable film to decrease the seepage effect. Here we use around 8 to 40% of zinc chloride solution. Most of the time these chemicals are used in combination, commonly the epinephrine and alum, epinephrine and zinc phenyl sulfonate, 4% epinephrine and alum, or 0.1% epinephrine and cocaine, zinc chloride and epinephrine, alum and aluminum chloride in combination. to achieve a optimum hemostasis and surface correlation. Usually the contraindications for the epinephrine is epinephrine may not be indicated in patients with cardiovascular diseases, patients with hypertension, diabetic, or patients with hyperthyroidism, patients who are taking Rolfia drugs or ganglionic blockers or antidepressant drugs, and also in individuals who have got hypersensitivity to epinephrine. And commonly, if it is used in a undamaged sulcus, it may not cause the side effects. If it is having an injured sulcus or so, excessive absorption may cause hyperepinephrine syndrome, which is characterized by tachycardia, that is rapid heart rate, rapid respiration, elevated blood pressure, anxiety, post-operative depression, and nervousness. So hence such patients need to be avoided, and epinephrine should be used in a patient's sulcus which is not injured or it is an intact sulcus. Commonly, to summarize, epinephrine has got good displacement and it has got a advantage of minimal tissue loss, but it has got a disadvantage of systemic reactions or epinephrine syndrome if there is a sulcus injury or the excessive absorption. Then alum, 100% potassium aluminum sulfate, it causes minimum tissue loss and it gives us an extended working time, but it comes with a disadvantage of less displacement and hemostasis than that of a epinephrine. Aluminum chloride causes minimum tissue loss, good hemostasis, so which is again a commonly used solution. Local tissue destruction in the concentrations more than 10% are used, so we'll have to be cautious about it. Ferric sulfate, which is also called as Monsell solution, has got good displacement, but it is little messy to use and it has got a very high pH and it can cause corrosion of a tooth structure or soft tissue. Ferric sulfate has got good tissue retraction but not compatible with epinephrine. Zinc chloride 8 to 40% has got good displacement, but in a higher concentration it may cause tissue necrosis and permanent tissue injury. Tannic acid 20 to 100% has got good tissue response, but in comparison with epinephrine it has got less displacement and minimal hemostasis. Negatol has got good displacement, but it may corrode the tooth and it is got a high pH. The retraction cords, which are commonly used to carry the chemical solutions, or it may be without the chemical solutions. So they are usually 100% cotton. They retract the gingiva and they also help in achieving a hemostasis when soaked with the hemostatic solutions. Retraction cords are commonly twisted, knitted and braided. All these designs ensures that there is no thin layer which will be left behind. So they are knitted, braided or twisted. Retraction cords, depending on the surface finish, they are waxed or unwaxed. Depending on the chemical treatment, they may be plain or impregnated. Retraction cords are available in various diameters and they can be categorized as a small, medium and large. In general, anterior teeth will take a smaller diameter or 000 or 00, and medium ones, that is 0 and 1, may be for posterior teeth, and large may be used in caution not to produce any tissue trauma with a thick tissue biota. So usually they are color coded: black 000, yellow 00, purple 0, blue 1, green 2 and red 3. So students should cautiously use and always select the largest cord which will fit without causing any trauma to the gingival tissue. Single cord technique usually indicated while making impression of one or up to 3 teeth healthy. It should be used in a healthy gingival tissue. It is relatively simple to use, and basically the cord of a required length is cut and it needs to be twisted to decrease the diameter and pull it around the tooth, neck of a tooth, and give a little apical tug and start packing the cord on the interproximal area, because the interproximal area, the sulcuses are little wide, and while doing a cord placement, it is said that this particular placement should be, the angulation of the instrument should be towards the root surface, and always continue to pack it from proximal area and gently, and while placing, the angulation should be towards the packed area than the unpacked area. Then once you continue to encircle, the other cord should be overlapped, and wait. Once you complete this entire packing, wait for 8 to 10 minutes before removing the cord, and while removing a cord, it should be soaked with water, so that dry cord may cause injury to the delicate sulcus epithelium. Gently dry, once you remove the cord, gently dry the area and make impression. Double cord technique usually used in a patients when the tissue health is compromised, excessive fluid exudates are present, and it may be used in a large sulcus, like as you can see in this diagram, triangular sulcus. And this particular technique, we have a smaller diameter cord is placed into the sulcus, and then the second cord of a larger diameter is placed above the first one, and after waiting for 8 to 10 minutes, the cord is soaked in water and removed and dried. The impression is made with first cord in place many times, or you may remove both the cords. The infusion technique, it comes with a special dental infuser with ferric sulfate medicament 15 to 20%. The retraction cord is packed into the sulcus for the first, then the infuser is used with a burnishing motion in the sulcus circumferentially all around the sulcus. That will effectively give you a good amount of tissue retraction. Then there is every other tooth technique, which is usually indicated when you prepare a multiple anterior teeth for impression, because placing a cord around all the teeth simultaneously may cause strangulation of a gingival papilla. So it is advised to place cords on every alternative teeth for a effective retraction. Rotary gingival curettage. This is another technique wherein it is also called as gingitage or troughing technique. Here the purpose is limited to removal of epithelial tissue while a chamfer finish line is being created. Usually the criteria for rotary curettage technique is the gingival tissue should be healthy and inflammation free. There should be absence of bleeding from probing. The sulcus depth should not be more than 3 mm. There should be presence of adequate keratinized gingiva. So these are the prerequisites for rotary gingival curettage. The technique, usually when you do a finish line, and after doing a finishing, you use a torpedo diamond and extend it apically 1/2 to 2/3 of the depth of the sulcus. And once you do this, you remove the inner lining of the epithelium with your torpedo burr. Once you do this, place aluminum chloride impregnated retraction cord and wait for the complete hemostasis to occur. Then you can go for impression procedure. Electrosurgical methods, these are again also called as troughing or gingival dilatation or surgical diathermy. A trough is created that extends into the crestal height of a gingiva to the point of around 0.3 to 0.4 millimeter apical to the finish line using a fully rectified current. The mechanism of action here is there is a controlled tissue destruction because the current flows in a small cutting electrode producing a high current density and rapid temperature rise at the tip, and the cells coming in direct contact of the electrode are destroyed and due to the temperature increase. Thus it creates a. So the indications for electrosurgical techniques are in case of areas of inflammation or there is a granulation tissue around the teeth, in cases where it is impossible to retract the gingiva, there is a to enlarge the sulcus and to control the hemorrhage, to remove irritated tissue that has proliferated over the finish line, and in crown lengthening. So you all are aware of crown lengthening. Whenever we have a short clinical crown, we tend to do a crown lengthening procedure. So electrosurgical method can be one of the options. Contraindications for electrosurgical methods are patients with cardiac pacemakers on an insulin pump, patients who have got a delayed healing due to debilitating disease or radiation therapy. The advantages of electrosurgical procedures is clear operating area without bleeding, healing by primary incision, lack of pressure to incise the tissue, less tissue loss after healing. It has got a disadvantage of unpleasant color, unpleasant odor during the procedure, slight loss of crestal bone may be there, burn mark on the root surface may be left over, and it is not suitable for thin gingiva biotech. And you should avoid any metallic restorations around, should not be contacted using your electrosurgical procedure. In the recent techniques, neodymium YAG lasers can be used or carbon dioxide laser can be used, and you can use erbium lasers or diode lasers can be used. The advantage of lasers is they are bloodless, painless incision, there is a controlled tissue removal, there is rapid healing. The disadvantage is it is relatively expensive and slower procedure. Retraction by dilatation of gingival sulcus, usually it comes as a gingifoam which has got a dual paste system. The base paste contains polydimethyl siloxane, the catalyst paste contains tin. On mixing these two pastes, hydrogen gas is formed, resulting in the formation of a foam, and this foam causes pressure on the pregingival margin. There are something called as compricaps, which are after filling over this, we place a compricam, ask the patient to bite for 3 to 4 minutes, then automatically the gingiva is retracted with the pressure of this swollen foam. The paste of aluminum chloride, kaolin and water is also another method which is delivered using a gun into the gingival sulcus, that also causes a very effective gingival retraction. Successful dental restoration mainly depends on the accuracy of dental impression, and impression can be a primary impression, a diagnostic impression, check impression which we tend to make during the steps of process of impression, process of tooth preparation to see whether the clearance is adequate, angulation is correct, and so on. And once we finish the entire preparation and soft tissue management, we make a final impression. It is important to know the properties of various impression materials and their effect when used with different impression material techniques. A dental impression, by definition, is a negative imprint or a positive digital image display of intraoral anatomy used to cast or print a 3D replica of anatomic structures that is to be used as a permanent record in the production of dental restorations or prosthesis. This is a GPT-9 definition. Various questions I have compiled from different universities. They have asked on impression materials and techniques for FPD. Questions like recent advances in impression techniques for FPD, disinfection of rubber-based impression materials, compare and contrast the properties of various elastomeric impression materials, monophase impression materials, combination method of impression techniques for FPD and implant, advantage and disadvantage of different implant impression techniques, describe impression techniques in implantology, recent advances of impression techniques in implant and FPD. Impression materials per se are hydrocolloids are the impression materials which have been used since long, which also have reversible, that is agar-agar, which gels and sols by change of temperature, and also irreversible hydrocolloid like agar. Agar is also another important impression material, which is a very essential component of FPD impressions, which is used for making models, opposite arch impressions, check impressions, and it is also made to make models for special tape applications. Alginates are type 1 and type 2. They are also having polychromatic alginates. There are also dust-free alginates with addition of glycerin or glycol, and they are also having silicon reinforced alginates to increase their strength. Then there are flowable alginates and tray alginates depending on their filler consistencies. The elastomeric impressions are the core impression materials for our FPD and implant impressions. The impressions, elastomeric impressions are basically a polyvinyl siloxane impression material, which has got a addition silicons and condensation silicons. Then we have a polysulfides, then we have polyether, then we have indentium. The condensation silicons are the and polysulfides are set by condensation reaction with release of byproduct. The polysulfides do carry with a disadvantage of unpleasant color and odor and taste. They are slow setting and they do have water as byproduct. And the condensation silicons do have byproduct which has got a relatively, which will be dimensionally little unstable. Then polyvinyl siloxanes are most versatile and dimensionally stable materials available in many viscosities, and they are hydrophobic in nature. Then polyether is relatively rigid, highly stable material, and it is the only hydrophilic impression material. Indentium comes with a combination of advantage of polyvinyl siloxane and polyether. That is good properties like a flow, elasticity of polyvinyl siloxane, and it also comes with a property of a hydrophobicity of a polyether, and it is a stable material. Just to recap the summary of impression, elastomeric impression, polysulfides have got polysulfides. Polysulfides are chemically setting with a byproduct of water, and they are hydrophobic in nature. So they should be poured within 30 minutes to avoid dimensional distortion. Condensation silicones, they are having a chemical reaction byproduct alcohol, ethyl alcohol, and they are hydrophobic in nature. So hence the material should be poured within 30 minutes of the um, making of impression. Addition silicon is the material which has got no reaction byproduct, but nonetheless there is a secondary reaction of moisture which can lead to formation of hydrogen gas, and this is a hydrophobic material. Pouring should be delayed for up to 1 hour, or it can be poured, stored and poured up to 7 days. Then the polyether, which is a rigid material, there is no chemical reaction byproduct in this material, and this is the only hydrophilic material amongst all the elastomeric impression material. And indenteum is another hydrophilic material, and this needs to be poured within 24 hours of the making of impression. Polyvinyl siloxane has got no chemical byproduct, but nonetheless secondary reaction between the moisture and residual hydrides of the base polymer may lead to development of hydrogen gas. This hydrogen gas, when poured immediately, may lead to pinpoint voids on the gypsum. So that is why platinum or palladium are added as scavengers in most of the present day materials, or delay the pouring by 1 hour or more to avoid this. Elastomers can be classified according to the chemistry as polysulfides, polysilicones, condensation silicon, addition silicones, polyether. Then according to the viscosity, they are light body or syringe consistency material, medium body or regular body, monophase material, heavy body or tray consistency, very heavy body or putty consistency. According to the method of polymerization, addition polymerization materials like polyether and addition silicon. These are the materials, they don't have any byproducts. Then the condensation polymerization materials like condensation silicones and polysulfides. Then according to the method of dispensing, they are single phase light activated polyether, two-phase systems like polysulfide, addition and condensation polysilicon, condensation silicons, two-phase systems having pseudo-elastic properties like single consistency material as a tray and syringe material. This is like a monophase material. Addition silicon is available as a monophase material. Then three-phase system with a thinner is a chemically activated polyether. Elastomeric impressions can also be classified as type 1, type 2, type 3 by ADA&C specification. And this classification is based on selected elastic properties and dimensional changes. Ideal properties required for elastomeric impression material, the surface detail reproduction, which is very essential property. According to ADA specification 19, there should not be the surface detail, fine details up to 25 microns should be recorded. And as the viscosity increases, the surface detail reproduction decreases. And light body records a fine detail up to 25 microns. Gypsum records a fine detail up to 50 microns. Putty material records of surface detail up to 75 microns. Dimensional stability, which is or according to AD specification 19, change should not exceed more than 0.5% after 24 hours. Usually the dimensional changes do occur because of the various factors like polymerization shrinkage, which should not exceed 0.5% of the volume. Then the polyvinyl siloxanes have 0.25% of linear shrinkage. Polyethyl ether has got 0.3 percentage of linear shrinkage. Polyvinyl siloxane has got polysulfide has got 0.45 percentage of the linear shrinkage. C silicons have around 0.7% of the 0.7% of the volumetric shrinkage. Loss of byproduct like byproducts in the polysulfide and C silicons will lead to dimensional stability. Like thermal contraction is another factor that has to be considered. When we stored in an ideal temperature of 23 degrees, and when we insert it in the mouth, it is around 37 degrees. This change in the temperature can also lead to thermal contraction. Water sorption, which comes into role in a material like polyether, which may tend to uh, absorb moisture and lead to dimensional instability. Tear strength is another important property, which is a resistance to break in the tensile force when removing from the undercut grooves or contact areas. So that is why it is important that the material has got good tear strength, and with respect to the tear strength, uh, we should remove the impression in a snap to avoid the tearing of the material in below the undercut or in the grooves. Then elastic recovery is when the material flows and sets in the undercuts, it should bounce back to its original shape. This particular elastic recovery is affected by the type of material, like polyvinyl siloxane and polyether have got 99% of elasticity, whereas C silicons have got around 98% of elastic recovery. And depending on the viscosity, the higher the viscosity, less is the elastic recovery. That is why, to minimize the effect of elastic recovery, block out the undercuts before making a impression. Then wetting is another important property that should be exhibited by elastomers. The lesser the contact angle on the surface, the better is the wettability. Except polyether, rest all the materials are hydrophobic. The polyvinyl siloxane comes with certain modifications like addition of the surfactants to increase the wettability. KES'S property, this is the behavior of the material to become less viscous under pressure. Polyvinyl siloxane and polyether are exotropic in nature. Shear thinning is material becomes more viscous under pressure. So this comes into role when we mix a monophase material and push it through the syringe, it becomes more fluid, and the same material is loaded on the tray and made a impression. So this is thixotropic properties or shear thinning property. The impression steps in impression making is the preparation of a tray. So whether it is a custom tray or whether it is a stock tray, we should select a tray of appropriate size, and appropriate space should be available for the material to be accommodated. The tray should cover all the desired areas of interest, and it should not impinge on any freeness. And tissue management, which is a very important step in doing a soft tissue management, retraction of the gingiva, and achieving the hemostatic and fluid-free atmosphere for proper recording of the margin geometry. Then manipulation of the material plays an important role in the success of the impression. Making of an impression, different techniques are there, which we'll see in the subsequent slide. Removal of impression should be in snap and it should be in a jerk. It should not be under rotation or twisting. That will cause a lot of strains incorporated in the impression. Preparing of stone casts and dies. Various types of impression materials trays are there in the market. The tray can be made up of metal or a plastic, or the tray may be perforated or non-perforated. Tray may be rim lock or non-rim lock. When comparing with the metal and plastic, it is metal which should be preferred as a material of choice, as it shows less tendency of flexion. If we use a plastic tray, there is always a chance of flexion and distortion. Then amongst the rim lock and non-rim lock, it is better to go for a rim lock tray, which will give a better mechanical interlocking between the impression materials and the tray. Otherwise, it will also prevent delamination of the impression material. The triple tray is another type of impression tray. There are segmental impression trays, which we can use it for check impressions. If we use a plastic tray, the plastic tray may flex during insertion, and when you withdraw it from the mouth, this may deflex. That will cause dimensional distortion. Then amongst the rim lock and non-rim lock trays will hold the material better and it prevents a delamination. And amongst the perforated and non-perforated, perforated trays are used for double stage impression, and we recommend a single non-perforated rim lock trays for single phase impression. Manipulation of elastomeric impression materials can be carried out by hand mixing. Hand mixing can be done with a stiff tapered spatula, wherein equal quantities of length of a base and catalyst are to be squeezed on a impervious paper, and the catalyst paste should be shifted onto the base paste, and continuous circular spatulation with the tip should be achieved, and then you spread the rubber base and spread it and squeeze it so that there is no air bubble incorporated, and you achieve a uniform color of a mix. Then static mixing is these are the specific mixing tips with ferrules inside are material specific, and they will achieve a good uniform homogeneous mix, and they also prevent contamination of the impression material during the mixing phase and during the delivery phase. And they are also going to save your material, unlike in case of a hand mixing. And you may ask me if the tip, if the dynamic static mixing tips are used, that much of material may be wasted, but we tend to waste more material in a hand mixing than the static mixing. Then there are electric mixing machines or dynamic mechanical mixing machine called pentamix. In this, usually polyether or polyvinyl siloxane materials are manipulated, and this will ensure wide, free, and uniform and homogeneous mix of the material. Techniques in FPD impression making: hydrocolloid laminate technique, copper band impression technique, putty wash, double mix, single impression. This means we mix two materials and we insert the tray 2 times. Putty wash, double mix, double impression technique with a spacer or with a putty cutback technique. Dual phase impression, dual arch impression, that is triple tray technique. Impression using vacuum adapted splints, functional check bite impression, matrix impression system, digital impression. So because of time constraint, I will just be considering the important methods in this particular presentation. Hydrocolloid laminate technique. This was suggested by Schwarz in 1951, wherein the gel was of agar-agar was injected using a syringe around the prepared tooth and the finish line, and a cold alginate was mixed and loaded on the tray, and that was pressed diagonally injected agar-agar. So the agars got gelled because of the cold alginate, and thus obtaining a good surface detail of impression, but it is rarely used in the present scenario. Impression using a copper band is another old technique wherein appropriate side copper band is chosen, and it is festooned at the cervical margin, and it is been trimmed and smoothened at that end, and you check the adaptation and mark the buccal or labial surface for a better reorientation, better recognition. And this particular copper band is filled with a impression compound. Earlier it was only impression compound or grease sticks were used. Now you can make an impression compound and scrape the inside surface and apply a adhesive, and you can inject a light body around the tooth and make a satisfactory impression of a single tooth. So this can be used for an inlay, onlay, or a single crown impressions. Custom tray. It is important that elastomeric impression materials are considered more stable when they are having a even thickness of around 2 to 4 mm. And to obtain this particular thing, we need a custom tray to be fabricated. Then custom tray should cover all the areas, and it should relieve the frenums. And for the lower, the handle should be in such a way that it should pop out of the mouth without interfering with the lip movement. And the transverse ridges are to be created on the posterior segment of mandibular trays for a easier withdrawal. Custom trays, the spacer thickness is an important thing. For a putty and light body impression, we require around 5 mm of a spacer thickness, around 3 mm of a spacer thickness for a monophase impression, around 1 to 1.5 millimeter of a spacer thickness for a light body impression only. Then to begin with, the spacer should be, you should mark around 3 to 5 mm of a from the apical margin of the free gingival margin. Then you cut the wax spacer, extend this wax spacer around 3 to 5 mm apical to the gingival margin. Then the stopper should be fabricated on a non-functional cusp. They should be in a quadruple or tripodal, 2 representing the posterior, 1 or 2 representing the anterior segment. The stopper should be on a non-functional cusp. Here on a mandibular, it should be on a lingual cusp. Maxillary, it should be on a palatal cusp. On a buccal cusp. And the posterior stopper should be at least one abutment distal to the prepared tooth, and it should be cut at the angle of 45 degrees to the cusp, non-functional cusp, and anteriorly it should be on a lingual slopes of a anterior tooth. Then to prevent the contamination, we should adopt a thin custom tray. Has got the advantage of less impression material because it has got a specific thickness of a spacer, and that makes it advantageous because the required material thickness, lesser the quantity or optimum is the impression, lesser is the polymerization shrinkage. Sterilization is not a problem as the tray is used only for one patient. Uniform thickness of the impression material minimizes the distortion due to the uneven polymerization. Then the custom tray disadvantages are it requires a time. The tray must be prepared around 9 to 10 hours before using to minimize the distortion. Otherwise, if it has to be made in a urgency, prepare a tray and put it in a boiling water for 5 minutes and allow it to cool to the room temperature and use, or put it in a polyclave and cure the tray. The residual monomer from special tray may cause tissue irritation in some patients. The tray adhesives are the tacky liquids which are applied on the interior surface of the impression trays before the elastomeric impressions are made, that they make the bonding more firm and more chemical adhesions can be achieved. Their tray adhesives are universal tray adhesives, specific tray adhesives, or spray adhesives, which may contain reactive silicone like polydimethyl siloxane or ethyl silicate. They should be applied around 8 to 10 minutes before, and most of the time students do make a mistake of applying it and going for manipulation of material immediately. Polymerization, this ensures the polymerization contraction is pulled towards the tray instead of towards the center of impression material. Thus, it minimizes the polymerization shrinkage effect on the impression dimension, as also it limits the delamination from the impression. The spray disinfectant, the tray adhesive should be uniformly painted, whether it is a rim lock tray, perforated tray, or a special tray. It is recommended to use a tray adhesive for effective bonding between the impression materials and a tray. The FPD impressions are single phase or double stage. Single stage means the putty and light body are mixed simultaneously and a tray is inserted at once, like light body and putty mixed together. Assistant mix the putty, light body is mixed in a gun by the operator. Monophase is a single phase material which is mixed and loaded in the syringe, and that is mixed and loaded in the tray simultaneously, and two materials are mixed and simultaneously set. And double stage, making of a space for the light body is done by using a putty cutter or a cellophane sheet or a wax spacer. The elastomers are available in various consistencies like a putty, light body, medium body, and heavy body. So the lighter the consistency, the better is the flow. The heavier the consistency, less is the flow. The heavier the consistency, less is the surface detail reduction. Whereas the lighter is the consistency, better is the flow and surface detail reproduction. Hence, the light body should be used to record the surface details and all the subgingival margins, and the heavy body should be used as a supportive material, and heavy body does undergo less polymerization shrinkage as there are more amount of fillers. So ideal impression should have around 70 to 80% of the heavy body and 15 to 20% of light body. The quash technique, that is double mix, single stage technique, wherein the assistant mix and loads the putty consistency, ensure that there is no excess material overloaded, and you do create a depression like a alveolar groove in the center of a tray for a proper position, and you mix the light body in a cartridge and you inject the light body. While injecting, you use something called as micro tip, which is essential to inject the material into the subgingival area and you need to continuously inject the material into the subgingival area around the prepared tooth. And once you do this, you can use a three-way syringe to gently spray air to ensure that the material flows into the gingival crevice. Then you continue to inject the light body. You can, at this stage, you can remove the microtip and continue with the injecting of material in such a way that circular motion and the entire prepared tooth should be drawn in the light body, thus ensuring that there is a good amount of light body around the teeth, and the loaded putty is slowly inserted intraorally. Take your time, don't hurry up and push, and take around 5 minutes of time and insert it and hold it passively in the premolar area. Don't give over pressure, that may incorporate a lot of pressure and there will be rebouncing effect. Then if you overpress during the setting, all the light body may come onto the border where the light body is not required to be. It looks like a border molding of impression. That is not a desired effect. So light body should be there in the finish line, light body should be there on the prepared tooth for a surface detail recording. Then the second technique is a putty light body with a spacer. This is a double mix, double impression technique, wherein there is a first putty impression made with a cellophane paper, but cellophane papers are around 20 to 40 micron thickness, and they are laminated on a putty and impression is made. Once the putty sets, the light laminated polishing sheet is removed, and this is how the tray looks like a semi-custom tray. Into this, the impression material light body is injected and from one end to the other without lifting the tip and ensure that sufficient amount quantity of material is squeezed and you can make an impression using this. So in order to get even distribution of light body. But the disadvantage of this technique is there may be uneven thickness of a light body as the spacer is 20 to 40 micron and it may be non-evenly distributed, causing some amount of defect in the impression. Then use of a 1 mm base plate wax spacer is recommended. You adapt a spacer with the stoppers and around 1 millimeter. You make a loader putty and you make an impression on the cast itself. And this is how the putty with the wax spacer appears. You take out this wax and then you inject a light body into the tray and go ahead and make a good impression. This will ensure uniform 1 millimeter of a light body material and that will be more uniformly distributed, even distributed light body for accuracy. Putty cutback technique wherein you make a putty impression without any spacer and with a J cutter, putty cutter, we cut the soft tissue undercuts, we cut interdental extensions, we cut drain channels on a palatal and buccal side, and we inject a light body and we make an impression. This takes time, but it is one of the best accurate technique. You will ensure the light body wherever it is required, and you will ensure good amount of thickness for putty and light body thickness wherever required, and will ensure that much amount of light body. So thus ensures effective impression. Single stage impressions in general are time saving and suited for single crowns, inlays, onlays, and laminates. Double stage techniques are time consuming and best suited for multiple or full arch impression. Special tray fabrication is best for monophase impression or putty or full arch. Functional check point impression recommended by Edwin Gates This is a combination of functional impression with a check bite impression. This is unilateral check bite impression is made with a medium body rubber-based impression material. Then a temporary is fabricated and temporary fixed partial denture in acrylic resin is fabricated. This temporary fixed partial denture is reduced around 2 occlusally and wax is adapted on the occlusal surface of reduced temporary and patient is asked to do centric and right lateral, left lateral, and this will do record the centric and excursive movement in the wax. Then after obtaining a wax, apply a quick setting acrylic on the opposite arch and cover the functional wax bite with a thin cellophane paper and well make the patient to bite in MIP to create a functional chewing record. Keeping acrylic index on the opposite arch makes the keeping the acrylic index on the opposite arch, you make an elastomeric impression of upper and lower arch. This will ensure you have recorded the functional chewing impression of the opposite arch and you have recorded the impression of the repaired tooth. Thus, this is a functional check biting. Then dual phase impression, wherein this is done with a special tray, wherein the monophase impression material is mixed and injected and around the repaired tooth and the same material is mixed and loaded in the tray and thus obtaining the dual phase impression. Heavy body material is loaded in the tray and thus obtaining a dual phase, that is a heavy body and light body combination. Dual arch impression technique as recommended by Wilson and Berry. This is also known as a triple tray technique, acubite technique or closed mouth impression technique. Here the simultaneous recording of the tooth preparation, opposite antagonist and interocclusal relation are recorded. Simple, accurate method for fabricating restorations using a conformative maxillomandibular. So this is recommended for use in a single unit restoration, inlays, onlays, or tabletop restorations. The triple trays are more flexible in nature, so that may incorporate some amount of dimensional inequalities. Triple tray, this is how the cross ridge should be ensured that this ridge goes distal to the last molar and tray adhesive should be applied only onto the borders of the tray, not on the mesh, which will prevent the bonding of upper and lower arch impression. Impression using vacuum adapted splints recommended by Antoine Leforgia in 1970. Here the vacuum adapted vacuum adapted temporary splint was fabricated and which was filled with a quick setting acrylic and while the acrylic is being set, you can feel the temperature change from outside of the splint. You need to remove and reinsert couple of times to avoid the blockout flow of the material into the undercut area. Then once the material is set, you remove that and internal surface and external surfaces are trimmed and the heavy body material is carried in the acrylic tray that is being fabricated and then make an impression. Then the occlusal vents, escape vents are made and after making the escape vents through the acrylic and the heavy body, a light body is loaded in the tray and made an impression. Then this entire impression assembly is fixed with a medium body impression. So this is recommended by Anthony Leforgia in 1970. Matrix impression system. This is suitable for full arch or multiple preparations, wherein a stroke tray with a medium viscosity material to pick a matrix impression was used. This is how the matrix adapted This is a matrix adapted, which is filled with a heavy body impression, and this matrix and heavy body are trimmed to contour of the pregingival margin. The interdental papillae are enlarged and trimmed, and thus this particular matrix is used to make a light body impression, and this will ensure that good flow of good recording of the subgingival margins. It pushes the gingiva away and it achieves the hemostasis and fluidless environment for everything. The entire impression is again fixed on a medium body. This is a matrix impression. Then the path of impression withdrawal, as I was mentioning, a point of note here is the maxillary arch. The teeth are divergent in nature, so it is recommended to withdraw the impression tray from the opposite side of the preparation. Whereas in the mandibular arch, the teeth are lingually inclined, and the tray path of withdrawal can be from the side of tooth preparation. Contamination is another important point to be observed in elastomeric impression. They do undergo direct contamination or indirect contamination. Direct contamination is because of the sulfur content, which reacts with the platinic acid catalyst of a polyvinyl siloxane, which may be uh, direct contact with the latex gloves or latex rubber band material. Using a polyvinyl siloxane, we should avoid using a latex glove. Use nitrile gloves, vinyl gloves, or polyethylene gloves. Indirect contamination comes from the tooth surface, so periodontal tissues, or from the gingival tissues, which may be due to the contact of the latex gloves on the retraction cords, on the tooth surface, and it should be avoided. And next is acidic retraction materials or hemostatic agents like aluminum or ferric acid, ferric salts may also cause contamination of the impression material. So hence it is recommended to wash these areas after retraction with the air and water or with the hydrogen peroxide or with the mouthwash. Immediate dentinal sealing agents or custom provisionals or provisional cements may also contaminate the surface. So to avoid this, always impression should be carried out, then temporary should be fabricated rather than preceding it. Then if at all, if you have contaminated with this particular sealants or provisional cements, it is recommended to clean the surface with alcohol and then polish it with a grease. Then disinfection of elastomer, which is an important step in preventing a cross-contamination from the patient to the laboratory and from the laboratory to the other arena of the clinicals. So disinfection of elastomer without affecting the dimensional stability, we can use 2% glutaraldehydes, 1 to 2% iodophores, complex phenolic compounds may be used. Sodium hypochlorite, 0.5% dilution as a spray or immersion for 10 minutes used to be. Commercial trade names of disinfectant like a dental MD520, which is a formaldehyde disinfectant. Jetta 7 disinfectant sprays by Germac. Dimenol disinfectant by Prosthodontics. These are some of the disinfectants available in the recent advances in rubber-based impression. There is one called VPS, which is a wash impression material incorporated with hemostatic agent to control bleeding and fluid flows, having 15% alum incorporated in this. So you need to make impression as well as retraction together. So this particular light body impression to be combined with called mega body tray material as a for a fine pickup impression. So this is a laminate technique Very include take one step at a time. Focus and give attention to details with respect to tray materials and associated tray adhesives and preventing of contamination. Do your best. Every day, various materials and techniques are being tried in dentistry. One has to be updated with the knowledge about them and utilize them for the patient benefit. With this, I thank you all for patience hearing, and I am available for any question and answers. Thank you.